Thank you so much for taking the time to watch this brief video that summarizes our approach to assessing medical students here at the University of Colorado School of Medicine. First and foremost, we need to address the question of why, or what is the overall goal of clinical assessment of our medical students. I summarize this by stating that the goal is to provide both the student and the school with helpful information on the student's growth towards becoming an independent physician capable of providing safe and effective patient care. Key things to note about this definition is that assessment has two people that it serves, the student and the school, and there's no mention of grading. Although assessment data is what is used to grade our students, our assessors should not worry about grading. Their goal is simply to provide information. In addition, the frame of reference that we use is that of creating an independent physician. So the idea of someone that goes off to residency able to do some of the skills that of a doctor on their own. And in particular, within the context of safe and effective patient care. So it's really this idea of how much support does the student need to be able to provide safe and effective patient care. As you may know, our University of Colorado School of Medicine curriculum has been greatly changed over the last few years. In this new model, all of our students complete their core clerkships in the second year in longitudinal integrated clerkships. During this time, they work with a preceptor in each of the core specialties for the entire year, as well as complete brief immersions in some of the core specialties. They then have 2 years to focus on more advanced skills and individualizing their curriculum towards their intended goal. Given these changes, at the end of the core clinical year, our students, we expect that they should be able to take care of patients with common concerns somewhat independently, not completely, but somewhat. And by the end of their 4th year, we really think about what is it that students need to be able to do on their first day of internship. As such, students are expected to take care of patients with common concerns completely independently, and those with more complex concerns with some input. All of our assessment data is gathered through OASIS. Be on the lookout for emails from OASIS with direct links to the forms. You don't need to remember your login if you click on the link from your email. In addition, all of our forms have 2 types of questions, ratings and comment boxes. Although OASIS does not have an app, you absolutely can complete them on your phone, which then also allows you to dictate if that is easier for you than typing out your comments. The tasks that you assess students on are what we consider to be the core tasks of being a doctor: gathering a history, performing a physical exam, developing a differential diagnosis, written documentation, oral presentation, and a management plan. In addition, there are several other clinical tasks that we deem important and want to get input on. This looks like a long list. Not all of these questions are not on every single assessment form. Each form is individualized, and you have some opportunities to decide what you want to assess the student on. When we think of the core clinical tasks, the questions are all phrased the same. For a patient with a common concern, if you were to supervise the student again, how would you assign the task to the student to assure safe and effective patient care? So again, the patient is at the center of all that we do, as we're really trying to make sure that we can create independent physicians who are providing high quality care. And again, the framework of this, the difference between substantial input or repeating all findings and minimal input or some findings, can feel pretty big for people. Remember, it is okay that you're repeating a lot or providing substantial input for students in their second year of medical school. Think about it from the patient's perspective. What would you let the student do if your first and foremost goal was about assuring safe and effective patient care? There's some common misconceptions about these ratings. First and foremost, billing rules do not apply. I know that I have to repeat everything on a physical exam for all students. This is why we ask about what you would do in the future. Think instead about the patient's safety and not billing. Similarly, selecting that a student is very independent in a task does not mean that they don't need teaching or feedback. Some of our very best students may be very independent, but yet still benefit from some small tweaks or feedback to go from good to great. And the flip side is also that idea that asking for help or knowing limits is part of being an independent clinician. It is not always a marker of a need for increased supervision. Finally, we recognize that the amount of supervision a student needs is different depending on the context or complexity of a patient. We know that independence is context dependent, that students probably become more independent with common presentations before they become independent with complex presentations. The key difference between common and complex isn't always just the diagnosis. A patient with a fever could be common or complex. The difference instead lies in the amount and complexity of the clinical decision-making or doctoring that is needed for a patient at this visit. This list includes some key differentiations between common and complex patients. A common patient has a single or a few uncomplicated concerns, routine problem solving, minimal intervention done, and follow-up care of a stable chronic condition. Complex, on the other hand, includes multiple problems that interact and require extensive decision-making. There's extensive testing or referrals or medication ordering, a patient who's undifferentiated, atypical presentations, or patients who need urgent or emergent care, or finally, that decision-making is heavily influenced by a complex social situation. Take this into consideration as if we note that a student is independent in some of the common conditions, we may ask you how your assessment might change for a complex patient. Finally, a key aspect of what we do is getting descriptions of what the student is able to do on their own through narrative comments. These are a few suggestions to make your narrative comments useful both to the student and to the school. First and foremost, our goal is for you to describe what the student is able to do independently with specific examples. This means using verbs and not adjectives, avoiding cliches, and including specific reference to those activities that we expect the students to perform. You'll know that you're doing this well if you note that you're describing specific patients or scenarios and that your comments include examples relevant to your specialty. In addition, we don't want you to compare students to other students or provide grades or say something like the student performed as an intern. What I do is when I find myself using an adjective or comparative language, I think to myself, what particular behaviors did the student demonstrate that made me think that they were performing at the level of an intern? Finally, our goal is to think about what the learner can do to move on to the next level. I describe this as the power of yet. There are certain things that a student may not be able to do now, but that they will be able to do in the future. Those are great suggestions for constructive feedback and helping the learner think about their growth to being a physician. In addition, we want to think about how bias influences our work in completing evaluations. There's a full separate video about equity and assessment that you can watch on the AEO website. But these 4 principles are some of the key things that help us to mitigate bias in assessment. Finally, I summarize this with the idea that your job as an assessor is to be the eyewitness and not the judge. Tell us what you saw in detail rather than providing your thoughts on a clinical grade for the student. And remember that each assessment is another pixel to provide more detail and more information on how that student is doing on their development from student to doctor. Even if you're uncertain whether your interaction is representative of the student's skills, complete the assessment, write it down. It's one more pixel. The more data that we get, the better we are able to understand how that student is doing and what support they need to maximize their potential. In conclusion, feel free to reach out to me with any questions about assessment. I'm always happy to review any of your assessments and provide you with feedback, or just to answer questions in general about assessment. Thank you so much for your time.